Hi, welcome back to PT Fine Med. Today I shall be discussing about heart attacks and more particularly myocardial infarctions. Now, first let me start with this clinical case scenario. A 42-year-old male comes to you who's morbidly obese and has a rather stressful lifestyle, mostly because of his occupation. He's a chronic smoker and alcoholic. Comes to you with history of exertional breathlessness, retrosternal chest pain, which tends to radiate to his left arm, and profuse sweating. What do you think it is? The first thought which comes to your mind is a heart attack. Yet at the same time, it may not be a heart attack. All right. So let me just explain exertional breathlessness or exertional dyspnea in detail over here. There's three main pathologies involved. One is cardiac, another is respiratory, or the miscellaneous involvement. All right. So now, if this cardiovascular system involvement, any left atrial failure, regardless of etiology, can cause exertional breathlessness. All right. So the left part of the heart is generally involved, and you cannot exclude the fact that the myocardium might be involved, so it can precede a heart attack. Okay. If it's a respiratory system involvement, then you have either interstitial lung disease or severe pulmonary emphysema or COPD. Okay, and then other causes can be obesity or severe anemia. All right. So that covers the causes of exertional breathlessness. Okay, retrosternal chest pain can either be localized over here or could possibly radiate to the jaw, up till the neck, or till the shoulder, the left arm, left forearm, or the ulnar, the border of the medial aspect of the left hand. All right, and there can be profuse sweating. So now, first let me discuss this group of diseases called ischemic heart disease. All right. So this refers to a set of heart diseases where there's inadequate supply of blood and oxygen to a portion of the myocardium. Okay, so myocardium is the middle layer of the heart. The outer layer over here is called the pericardium. The middle layer is the myocardium, which is mostly muscle. Okay, and then there's the endocardium. All right. So in this muscular layer that's been colored pink, it's called myocardium. When that receives less oxygenated blood, then it's called as an ischemic heart disease. Okay. So under that you have two things. One is called angina pectoris, and then there's myocardial infarction. Okay. So now let me shift over here. Angina pectoris is what precedes myocardial infarction. Okay, so let me break down this wall of text for you over here. There's sudden onset of intermittent retrosternal constricting type of chest pain. It can last anywhere between more than 30 seconds to less than 30 minutes. Radiates to the left shoulder, medial aspect of left arm, left forearm, and the ulnar border of hand. Okay. And it occurs on exertion or cold exposure, can be relieved on taking rest and anti-anginal drugs like nitrates. All right. So that's angina pectoris. And severe form of angina can precipitate in myocardial infarction. Okay, so I shall get to later. First, let me explain what can cause angina pectoris. So basically, repeated attacks of angina can also lead to myocardial infarction. So it's important that it should be recognized as soon as possible and be treated instantly. So what causes it is basically atherosclerotic plaque buildup. Okay, so when you have increased cholesterol levels in the blood, when that deposits, then you have a stable atherosclerotic plaque. Okay, seen over here. Now let me just put this out. As you can see, there's a pretty thick fibrous cap over here. All right, and there's no cholesterol cleft deposits over here. It's just stable atherosclerotic plaque. Okay, at this point it will not cause any trouble, but the more it occludes and more it deposits along the tunica intima layer of the vessel, the more it produces inflammatory cells along with cholesterol clefts, and the more it's likely to also have necrotic changes. All right. So this is a stable atherosclerotic plaque and can be seen in stable angina. Okay. So there's three types of anginas. Sorry, I didn't explain this. There's stable angina, there's a variant of Prince metal angina, and there's unstable angina. So in the stable kind, you have this stable atherosclerotic plaque. All right. And basically it's mostly seen deposited along the coronary arteries, And when there's increased myocardial oxygen demand, such as a physical activity or nutrition or emotional excitement, the demand for the oxygenated blood in the myocardium increases, but this demand cannot be met by the coronary arteries because of such deposits. Okay, so the pain soon forms, and this can be relieved also on taking rest for a while or on taking anti-anginal drugs. Okay, so that's stable angina. Then there's a variant of Prince-Metal type of angina, which is mostly based on, it's not based on the exact amount of arteriomatous plaque being deposited, but rather there's a vasospasm. Okay, so now if a vasospasm happens in a person without a plaque, he won't feel much of the pain. Whereas someone with the arteriomatous plaque, there's suddenly very much reduced blood supply to the myocardium because of this vasospasm, right? And it's not related to physical activity or heart rate or blood pressure. It's just the spasming of this coronary artery. So that suddenly reduces blood supply to the myocardium. And how do you treat this? Well, since this happens at rest as well, taking rest clearly is not a solution for this. You just have to promptly take vasodilators, all right? And then there's the unstable arteriomatous plaque, okay, or vulnerable plaque formation. Over here, you can see there's a very thin fibrous cap compared to here, a very thick fibrous cap. There's thin fibrous cap formation. There's cholesterol clefts present there, okay, and more of the lumen is also occluded, and there's also inflammatory and necrotizing cells present. And this plaque, what makes it so vulnerable is that it's more prone to fissuring or ulcerating, all right? And when that fissures or ulcerates, there's increased thrombus formation. So this means that there's increased deposits of platelets which adhere and aggregate at this site, and there's thrombus formation around the whole thing which can block off the entire artery. Okay, so that's unstable angina, and this takes place even at rest, and you have to treat it instantly the moment it gets recognized. Right? So basically, you may progress to myocardial infarction at this point because repeated anginal attacks or increased intensity of the anginal attack can cause a myocardial infarction. Okay, so it has to be treated instantly. So multiple vessels can also be affected at this point. And now let me move on to the next topic, that's myocardial infarction. Since I've name dropped this multiple times, let me explain what it is. Myocardial infarction is nothing but coagulative necrosis of myocardium, that's the cardiac muscle, due to prolonged severe ischemia. Right? So that's the difference between angina pectoris and myocardial infarction. Angina pectoris just refers to the pain and discomfort felt. Myocardial infarction just refers to the death of cells where undergoes coagulative necrosis. Okay, and now what is cardiac arrest? Now, since this terminology is often very commonly interchangeably used, people often mistake it for a heart attack, but actually contrary to what the name suggests, cardiac arrest does not mean that the heart stops beating, but rather the lungs. So there's sudden stoppage and beating of the heart as well as the activity of the lungs. Okay, so this basically the moment there's decreased oxygen, there's decreased breathing, or this decreased circulation, interchangeably one of the other events can happen. That is, suppose the breathing stops first, then the heart can stop beating. Or if the heart stops beating, then the lungs stop expanding or contracting. As a result, there's a decreased blood supply to the brain. All right, so that is cardiac arrest. So it means there's a problem with the heart and lungs. Okay, now let me move on to myocardial infarction. Right. So myocardial infarction, as I just explained, it's nothing but coagulative necrosis of cardiac muscle due to prolonged severe ischemia. Okay, and also can be called as acute coronary syndromes. Myocardial infarction and angina pectoris, as well as ischemic heart disease, can be called acute coronary syndrome because of extensive involvement of the coronary arteries. Right. Now, let's move on to the risk factors. What can precipitate a heart attack or myocardial infarction? So one factor, let's look at the non-modifiable risk factors, such as age and race. Okay, so age, the most common age group where you find myocardial infarction is 40 to 65 years. All right? And, but these days, increasingly due to large changes, increase in sedentary lifestyle and more stress, occupational stress and type A personalities, The age at which people are experiencing myocardial infarctions has dropped. So these days, people as young as 25 are experiencing heart attacks. All right. So you cannot just rule out a person just simply because they're too young to get a heart attack. It can happen even as young as 25 years. Okay. Now, the next non-modifiable risk factor is race. So Caucasians are more prone to developing myocardial infarction than Negroids, and Indians, however, have a really high risk factor. Okay, partly it's because the average diameter of the lumen of our arteries is much smaller compared to Western countries. So even the slightest build-up can show a significant change in our perfusion rates. All right. Now, moving on to modifiable risk factors. So as I discussed earlier, the atherosclerosis plaques. So atherosclerosis is a major risk factor. Okay. Then there's hyperlipidemic states, with increase in lipids in the blood. Okay, particularly the cholesterol levels, like low density cholesterol, very low density cholesterol levels. Then you have hypertension and diabetes mellitus. These two often fit hand in glove. Hypertension can precipitate myocardial infarction, and particularly diabetes mellitus. Diabetes is particularly notorious because it can cause microvascular and macrovascular changes. All right. So as a result, fibrinolytic activity is often impaired. So there's increased time to break down a clot, which is formed in the blood. And often these fibrin products are glycated. And even around the heart, there's increased glycation taking place. And as a result, the effect of angina cannot be felt in diabetics. So they often experience something called a silent MI. Okay, I shall get to that later. Cigarette smoking is also a very significant risk factor. It often precipitates heart attacks because of its effects on platelet and also vasoconstriction. Okay, nicotine particularly is to blame. Then obese individuals are also at high risk of developing myocardial infarction. All right. Then chronic alcohol use can also precipitate as myocardial infarction. Then there's also hereditary involvement, especially amongst first-degree relatives. So you have to look at family history. Then sex. Now, testosterone has a rather dangerous effect on the heart. So as a result, males are more prone to developing heart attacks. Testosterone is very dangerous for the heart. Estrogen, however, has a cardioprotective effect. So as a result, most women, especially in the reproductive age group, are less likely to develop myocardial infarction, except for those in the menopausal age group, because there's less estrogen in their systems. So as a result, the protective effect of estrogen is no longer in the menopausal age group. So they're just as prone as men by the time they reach menopause. Now, moving on to the etiology. Okay, so this can be divided into atheromatous and non-atheromatous causes. Okay. So you have coronary atherosclerosis accounting for 90% of cases, where there's increased buildup in the coronary arteries. Then there's non-atheromatous causes, that's accounting for 10% of cases. So one is vasospasm, another one is emboli. Okay, so emboli is when embolus tends to form in coronary arteries, it can result from left atrium, okay, in association with atrial fibrillation, because of this chronic stasis of blood pooling up in the left atrium. It coagulates and it can easily embolize. All right. Then also left side mural thrombus, vegetations due to infective endocarditis. Intracardiac prosthetic devices can also attract lots of vegetations, and something called paradoxical emboli. So emboli from the right side of the heart or peripheral veins can travel through a patent foramen ovale or any septal defect in the atrium or ventricle and reach left side of heart. From there on, it can travel through the coronary arteries. All right. And then there's ischemia due to vasculitis. Okay, ischemia refers to decreased blood supply to the point of causing tissue death. So vasculitis or sickle cell anemia, all right, or amyloid deposits in the vascular walls. And then there's vascular dissections, particularly of aorta, and decrease in systolic blood pressure resulting in shock. All right. Now, moving on to the pathogenesis of myocardial infarction. What's the steps which leads to the buildup to a myocardial infarction? All right. So over here you have a normal coronary artery. As you can see, an entirely clear tunica intima. There's no deposits around it. The whole lumen is clear. Then you find atherosclerosis building up. There's an atheromatoous plaque or cholesterol clefts developing beneath the surface, and it becomes an unstable one. Okay, so there's acute plaque change because the plaque can either rupture, fissure, or ulcerate. All right. Then there's increased platelet adhesion and aggregation at the site of rupture of the intima. Then there's thrombus formation over it around that atheromatoous plaque. So it's formation of the occlusive thrombus. So this subsequently stops blood supply to the myocardium. All right. That's pathogenesis. Now, what arteries are commonly involved? The most common ones are left anterior descending, okay, left circumflex, and right coronary artery. Left anterior descending artery most commonly causes anterior wall MI. Okay, it's most common artery involved, and it's also known as widow's artery because mostly occurs in men, particularly between age group of 40 to 60. And as soon as the blockage forms in their left anterior descending artery, they tend to die. So often leaving behind widows. Okay, that's a sad story, but you get the point. Okay, so left anterior descending artery can cause an anterior wall MI. Let's take this as the anterior part of the heart. Okay, this is lateral. So right coronary artery MI blockage can cause lateral wall MI. Okay, left circumflex artery can cause a posterior wall MI. All right, and you also have inferior wall MI, which is basically depending on the dominance of the blood supply. Suppose the left coronary artery is more dominant over right coronary artery, and if blockage takes place in left coronary arteries, then there the inferior wall can be affected. Or if it's right coronary artery, which is more dominant, and if that gets more blocked, then that can cause inferior wall MI. All right. Now, the reason why I brought up inferior wall MI, but couldn't plot it here properly, is because the prognosis for inferior wall MI is actually much better provided it's diagnosed in time. It's often overlooked in ECGs, whereas anterior wall MI often has a more poor prognosis rate. And even similar to inferior wall MI, even posterior wall MI can also be a bit difficult to diagnose. I shall get to the details of that later. All right. Now, moving on to the consequences. So you have reversible and irreversible consequences. Let me start with reversible consequences. So you have the biochemical changes, okay, the functional changes and morphological changes. So biochemical changes, there's cessation of aerobic glycolysis, okay. So the aerobic breakdown of glycogenic products in the myocardium suddenly stops, okay. So because there's decreased breakdown, there's decreased ATP formation and decreased breakdown of ATP, okay. So there's less energy being used. As a result of decreased aerobic respiration taking place, there's increased accumulation of these toxic products, okay, the toxic metabolites such as lactic acid that suddenly builds up in the heart muscles, okay. Now, functionally, there's loss of contractibility. This can precipitate acute heart failure, okay, because there's less contraction because it goes into an energy saving mode. Then morphologically, you find mitochondrial swelling because of this increased ATP deposition and decreased breakdown of ATP and production of ATP. And you find glycogen depletion because suddenly it all gets used up and there's nothing new being formed or to be broken down. And there's myofibrillar relaxation. The myofibrils decide to relax. As a result, there's no increased activity amongst them. All right. Then moving on to the irreversible changes. Biochemical changes includes leakage of cytoplasmic proteins into the blood. Like this includes myoglobin, LDH1, and CKMB, that's creatinine kinase MB proteins, and troponins INT. These are very important, and I shall explain later why they are. Functionally, you find arrhythmias being formed. Okay. Morphologically, there's coagulative necrosis of cardiac muscle fibers. Okay. So those are the consequences of the immediate consequences of myocardial infarction. Now, how do you classify them? You classify it based on, apart from the wall involved, you classify it based on the thickness of the ventricle that's been affected. So you either have transmural infarcts or subendocardial infarcts. Okay. So subendocardial infarcts, it's just at the endocardial layer, just at the surface. Either the inner 1/3 of the ventricle wall or the inner half of the ventricle wall can be affected based on thickness. This diagram represents that. Transmural, this is more dangerous as the entire ventricle thickness is involved. Okay. Now, morphologically, what happens at the pathological level? Okay, those of you taking pathology, this will be more important for you. So, on gross appearance, within the first 12 hours, you can only detect an infarction has taken place based on histochemical staining only. Okay, from 12 to 48 hours, you find a yellow tan appearance and it's soft to feel. Within 3 to 5 days, you find a central pale area that's formed. It's highly necrotic and there's a hyperemic zone around it. Okay, and from 10 to 2 weeks, 10 days to 2 weeks after the myocardial infarct, myocardial ischemic attack has taken place, you find that the entire tissue has become soft and there's still a hyperemic zone around it. And after 2 weeks, you find that there's fibrous scar formation around the area, the whole area. Okay, so that's in gross. Microscopically, you find this is normal myocardial fibers. Okay, so you find that there's branching out, then there's intercalated discs, and you find the ovulation nuclei looks healthy, right? Now, within 12 to 8 hours, you find that there's the infarcted myocardial fibers with eosinophilic cytoplasm around this whole area. That's why it's colored orange. Okay, then there's nuclear changes of necrosis like pycnosis and karyolysis. All right, so basically this breakdown of these entire fibers. This whole overall structure is maintained, but inside all cells are broken down, right, because of coagulative necrosis. Then that's from 12 to 18 hours. Now on the first day, you find necrotic myocardial fibers that are broken down entirely. Okay, and you find increased lymphocytic infiltration. That's polymorphonuclear neutrophil infiltration around the area. Okay. Then within 3 weeks, you find that there's necrotic myocardial fibers. Okay, here it's completely broken down over here above. That's there. Okay, then you find increased deposition of collagen, macrophages, fibroblasts, and capillaries. That's basically granulation tissue forming over there for repairing. And within 3 months, you find that there's nothing but fibrotic tissue. So there's fibroblasts, there's capillaries, there's lymphocytes, and scar tissue overall. Okay, so that's after 3 months. So that's the morphological changes. Now, how do you diagnose this? Clinically, it's very important because myocardial infarctions not only has a very high mortality rate, but also causes a lot of disability. Okay, so it's important that it's very crucial that you diagnose this as soon as possible. So symptomatically, we probably have a rough idea by now that the severe retrosternal chest pain, there's exertional breathlessness, and this retrosternal chest pain may or may not be there, especially in silent MI. So radius to the neck, jaw, and epigastrium or the left arm. There's a rapid, weak, and steady pulse. There's profuse sweating, and there's exertional breathlessness because of pulmonary edema, hence it's exertional dyspnea. And 10 to 15% of MIs, especially in diabetics, are called as silent MIs. Okay, so they often tend to die in their sleep because they can't feel the pain. The angina is nothing but the body system, body's way of saying, help, I need help, there's something wrong with me. All right, please take action. That's the concept behind it, the angina pectoris. All right, so in diabetics, they can't feel this pain. So often they just feel extreme unease and discomfort and sweating and breathlessness. Okay, so breathlessness is a much more reliable symptom than the pain. All right. Now, moving on to the ECG changes. I shall take a separate class on ECGs. That's normal ECGs and abnormal ECGs later on. Okay, but for now, just learn this. There's classically you find MI can be divided into two types. One is STEMI and NSTEMI. Okay, STEMI is STEMI. It stands for ST elevation myocardial infarction, and NSTEMI, that's non-ST elevation myocardial infarction. Okay, so in STEMI you often find that the ST segment is elevated, all right, in conjunction with a T wave inversion, and there's deepening of this Q wave over here. Okay, the deepening of Q wave and T wave inversion often reflects on if there's any scar, any fibrotic tissue forming, and any necrotic changes. Okay, sometimes you find the ST segment can also be depressed. Okay, along this is often in NSTEMI, the ST segment is depressed, but the T wave inversion and deepening of the Q wave can still remain. All right. And ST segments can be elevated in a lot of normal ECGs. I shall teach you what to look for in the ECG class. All right, and hopefully I shall take this soon. All right, so those are ECG changes. Now, lab findings. What do you find in lab findings? So these are certain markers you have to look for in blood work. Okay, so you have the myoglobin, which is increased within 1 to 3 hours, so it's elevated very rapidly, and it stays in the range and returns back to normal range within, it's elevated and returns back to normal range within the first 24 to 36 hours after the attack. Okay, so it's not very long lasting. Then LDH1 has to be analyzed. You don't look at total LDH because it can be secreted by other parts of the body, pretty much everywhere else. So you look at LDH1 because this is more cardiac specific because it's present within the cardiac cells. Okay, and this lasts for 7 to 14 days. All right. Then there's creatinine kinase MB. This is found in the skeletal muscles, brain, and the myocardium. Okay, so it's non-specific and it's elevated for 72 hours. And now I put a star next to cardiac troponins. Okay, so cardiac troponins I and T. The reason why I put the stars is because this is the actual gold standard. So clinically, if you cannot pick it up, if you still can't rule out myocardial infarction, and if the ECGs aren't reliable, or if you have NSTEMI, then that's when you look at cardiac troponins. Okay, these never go wrong. So the elevated as soon as 2 to 4 hours. Okay, it peaks at 48 hours, and it remains in the blood system from 7 to 10 days. Okay, so it increases by 2 to 4 hours, peaks at 48 hours, and remains elevated for 7 to 10 days. All right, so it's cardiac troponins I and T. So all these cardiac enzymes are typically trapped within myocardial, right, in the heart cells. And the moment there's an attack, like the moment there's decreased blood supply and it dies out, all these enzymes, they leak out from cytoplasm into the bloodstream. All right, so that's when you detect it. All right. Now moving on to the complications of MI. Why is it so important? Well, simply because, as you can see, the list of 10 complications is listed out here. Let me simplify it for you. What does it mean, each and every one of these complications? So the risk of complications depends on infarct size and the location and thickness of myocardium. And as I mentioned earlier, the location, well, for starters, anterior wall MI is more dangerous. And thickness, that's a transmural infarct, is also more dangerous. Okay. Now let's look at left ventricular failure and cardiogenic shock. So ventricular failure is the most common cause of death. Okay. And often there's a really large infarct, which can affect more than 40% of the left ventricle, can lead to cardiogenic shock, which can cause, the cardiogenic shock can cause the congestive cardiac failure. All right, it's more commonly seen in elderly people. All right, so if there's mild dysfunction in the left ventricle, then can lead to pulmonary edema. But if there's severe dysfunction, then can be more fatal. All right, so there's less contraction of the ventricles because of this fibrillation. Then arrhythmias. Most MI patients, they can develop abnormal cardiac rhythms. Okay, and this includes sinus bradycardia and tachycardia, ventricular tachycardia, and ventricular fibrillation. All right, and the inferoseptal infarcts, you can find partial or complete heart blocks. Okay, that's below the level of the septum. Now, looking at myocardial rupture, there's increased necrosis and neutrophilic infiltration at the tissue site. So as a result, it makes it more prone to cardiac rupture because there's softening as well. And most frequently occurs during 3 to 7 days after transmural infarcts. And the rupture of the ventricular free wall can also occur because of hemopericardium and cardiac tamponade. So suppose this is the heart. Let me just draw it here. This is the ventricular wall. This is the septum. So I think there's a rupture here. There's increased flooding of blood. Okay, sorry, this wasn't caught on tape. So this is the ventricular wall and this is the septum. And suppose there's perforation here. There's immediate perfusion of blood into the pericardial layer. Okay, past the myocardium into the pericardium. So suddenly it fills up. Right? And subsequently the whole layer of the heart can also rupture. Okay. So if there's infarct of the wall of the left ventricle, there can be rupturing of the infarct into the pericardium, which causes blood to flow in. So this causes cardiac tamponade. Okay. So it's hemopericardium and cardiac tamponade. And there's rupture of the ventricular septum. It's less common. And okay, sorry, here. Rupture. So this can lead to an acute VSD, ventricular septal defect, and a left to right shunt. So suddenly oxygenated blood from the left side is suddenly flowing into the right side, where there's deoxygenated blood. All right, this is a rare cause. And rupture of papillary muscle, it's least common cause due to acute severe mitral regurgitation. All right, there's complete incompetence of the mitral valve, and there's rupturing of the papillary muscles. All right. Now moving on to the next one, that's dilatation of ventricular chamber. The area of the infarct being a weak region may be disproportionately stretched. Okay, so there's constant stretching of the myocardium there, and then there's dilatation of the infarct region, especially anteroseptal infarcts, but still not severe enough for an aneurysm to follow. Okay, so there's complete dilatation of that ventricular chamber because of the stretching. Alright, now moving on to ventricular aneurysm. So after acute transmural infarction, the affected ventricular wall may bulge outwards, alright, during systole. This causes a ventricular aneurysm. So the dilatation of ventricular chambers can progress to a ventricular aneurysm, alright, and this is a late complication of large transmural infarcts. Now moving on to mural thrombus. Now the infarct can cause local abnormality in the myocardial contractibility. Okay, so the stasis. And this endocardial damage creates a thrombogenic surface. Okay, so because of the increased blood stasis and the damage to the endocardium, there's increased deposition of thrombi at the surface, right? So this can occur within the ventricular aneurysms as well. Now, next complication is pericarditis, and this is because this has two types. One is early pericarditis and delayed form pericarditis. So early pericarditis, a transmural infarct, can involve the pericardium, causing a fibrinous or fibrinohemorrhagic pericarditis. This happens within the second or third day after the attack. All right? And delayed form of pericarditis, that's post-myocardial infarction syndrome. It's also called Dressler syndrome. Let me just write this here. So you have early and you have delayed / Dressler syndrome. Alright? So you have Dressler syndrome, and this develops within 2 to 10 weeks after the infarction. Okay? It's probably immunologically mediated. So early pericarditis is often due to acute inflammation, whereas late pericarditis or delayed, it's often because of an autoimmune mechanism. Okay, Dressler syndrome can be autoimmune involvement. Oh, that reminds me. It's Dressler syndrome. Now, moving on to extension of the infarct. Okay, so new areas of repeated necrosis can occur adjacent to the existing myocardial infarct. Okay, so the infarct can extend. All right. So, in extended infarct, the healing is more advanced in the central zone than the peripheries. All right. In contrast with simple infarcts, where healing is more advanced at the periphery. All right. And the cause of extension can be due to retrograde propagation of thrombus or proximal vasospasm, microemboli, or arrhythmias. Right? Then infarction of right ventricle is unusual. However, part of the right ventricular myocardium may be involved with infarction of adjacent posterior left ventricle and ventricular septum. Okay, so there's venous circulation pooling, which causes systemic hypotension. All right. Now, moving on to infarction of right ventricle. Oh, sorry, I just repeated that. I'm so sorry. Okay. Moving on to progressive late heart failure. This is seen in chronic ischemic heart disease and usually develops due to functional decompensation of the hypertrophied non-infarcted myocardium. All right. Sorry for the long drawn out explanation of the complications, but I should get to treatment right now. Okay. So for treatment, I remember it based on the mnemonics, just MONAC. Okay. So first are general measures. So first you start with CPR, just chest compressions, and you keep an eye on the breathing as well. Remember that the ratio should be 30 compressions is to 2 breaths in adults. All right. Then you use this system which I call as MONAC. Okay. So MONAC stands for morphine, oxygen, nitroglycerine, aspirin, and clopidogrel. All right. So morphine is often used for pain relief, and you inject it. And you have to keep a careful eye on the effects of morphine because it can often be vasoconstrictive in nature. Okay, so you have to use it in high dilutions. Then there's oxygen therapy to keep the patient's respiration in process. Okay, and to provide as much oxygen to the myocardium in the process as well. So the patient has to inhale about 4 liters of oxygen, okay, often through nasal cannulation or a gas mask. Sorry, face mask, not gas mask. And then there's nitroglycerin. So you have glycerol trinitrate, or you have isosorbide nitrate. So these can be provided in form of buccal spray, which is actually, that's a new form. Traditionally, it used to be sublingual route, where the patient has to chew on it, crush the pill with his teeth, and then immediately stick it under his tongue. And because of the lingual artery supply, that immediately links up to the heart, causing almost instant relief, where there's dilatation of the coronary arteries. All right. So this is probably one of the most important drugs to be used. Then aspirin can also be given instantly, where the patient has to chew on the aspirin continuously. Okay. And clopidogrel is an antiplatelet drug, and this can be given subsequently. Okay. So this is when you immediately suspect that a myocardial infarction is taking place. Then you take an ECG based on whether you detect STEMI or NSTEMI, and you also look at elevated cardiac enzyme levels. If that's confirmatory, then you admit the patient to a cath lab or cardiac care unit, where they undergo thrombolytic therapy or beta blockers wherever indicated. Unless it's contraindicated, that's the only time you do not give beta blockers. Or you treat any of the complications which I explained earlier, such as arrhythmias or left ventricular failure, myocardial rupture, aneurysms, or extension of infarct, thrombus, etc. All right. So for thrombolysis, you often use streptokinase, which is it's mostly used in India, and it's banned in the US and the European Union. These days they use activated tissue plasminogen activator. All right. Then they also use urokinase, which is much safer than streptokinase. Okay. Then beta blockers, you have the cardioselective effects such as atenolol and the likes. And for complications, as I explained earlier, you have to treat it as soon as possible before the symptoms can progress any further. Right? And that was myocardial infarction. If you like the videos, please feel free to hit the like button. Subscribe if you want access to more such videos. And hit the bell button if you want notifications for any future videos. Thank you.